Okay, well, good afternoon, everyone. It's my pleasure to be here with you and talk about thoracic trauma, which is the third part of our lecture series today. I couldn't help but notice there's a lot of people in here, and it's more than we would usually let in, but what the hell, we'll just all get along with each other. It did remind me, though, of one situation in my life that some of you may have shared. My first day in undergraduate work, knowing I wanted to go to medical school. So I knew that, I had to get good grades in chemistry. That was very important. And in my first year, I was at Hopkins, and there were 550 people in my class. 350 were pre-med. So you can imagine the competitive atmosphere that created. Well, the first day of inorganic chemistry, the professor walked out, and he probably looked at something very much like this. And he just put his head down and he looked up. He said, after the midterm, there'll be seats for everyone. And he was right. There were plenty of seats after the midterm. So we have that test ready? Okay, we're not going to do that. Okay, so anyway, let's get started. We have a lot of material to try to cover. I'm going to work from the outside in. We're going to talk about chest wall trauma just a bit. And all these topics are going to be just hit upon because we really don't have such a great amount of time. We'll talk about lung injuries, pleural injuries, and we'll move on to the major arterial system in the chest, specifically the aorta, which is the big bad boy that we have to worry about. A little bit about esophageal injury, which actually is so uncommon it probably doesn't deserve a great deal of attention, but we'll mention it. I will talk a fair amount about major airway injuries, which we can do a lot about diagnostically. And then if we have time, hopefully I'll be able to talk about cardiac and pericardial injuries. All right, so let me start you with this case. It's an entity you may not know about. This entity was described in 1980 from the orthopedic surgeons at the Shock Trauma Center where I work. And you'll notice from the chest radiograph that we have a number of fractures of the scapula, clavicle. There were rib fractures here. And even more interestingly, if you look at the reformatted volumetric image, you can see that the scapulae are markedly displaced laterally. And then if you look at this image of the vascular structures, you can see that the axillary arteries are both occluded. Okay, now this is something called scapulothoracic dissociation. It's an entity that a lot of people aren't familiar with, but certainly occurs in major trauma. And its import is, of course, recognizing what can be active bleeding in the subclavian or axillary arteries. So here are the major features of this entity. It produces a 4-quarter amputation, which is closed. The skin is intact. There's a huge amount of edema and hematoma over the shoulder, but it's not always appreciated clinically. It's a traction injury. Something pulls on the arm. Probably the most likely scenario is the arm is sticking out of the car. In case you drive this way, the arm is sticking out of the car and something comes along in the other direction and decides to pull it out. Nerve innervation of the arm is usually interrupted. There is almost always major vascular injury. The fractures of the extremity you've seen, the hematoma you appreciate, and the lateral displacement of the scapula. All of these typically fit together, and it's a very clear-cut injury. Unfortunately, assuming you take care of the bleeding, ultimately these patients have an insensate, non-functioning arm, and about 40% of them at least come to total amputation. Here's just one more example of that. You can see that the scapula is way out here laterally. It's not superimposed over the chest at all. There is a great deal of soft tissue density, which we're seeing. If you look at the volumetric image, you can see how the scapula is completely displaced. The clavicle is avulsed from the acromion. And then in this patient, we have active bleeding into the axillary region, which obviously makes this an emergent situation to diagnose. I'll give you a moment to look at this one. It's not common, very important to appreciate. And hopefully you'll recognize that the clavicular head is posteriorly dislocated. And I'll give you some more images of the same thing. And what we worry about when this occurs, of course, is damage to the underlying structures. Frankly, I've seen a fair number of these cases now, and I have very seldom seen one of the bad things that can happen, like arterial injury or airway injury or esophageal injury. It doesn't occur very often. Mostly what I've seen is partial occlusion of the brachiocephalic vein. But still, one needs to look for these types of injuries and anything else that may occur as a result of this displacement. It's easy, probably the easiest to appreciate in the simple axial view through the articulation. But if you want to get fancy, you can show it in three-dimensional volumetric imaging. It's not real common. If we look at the incidence in shoulder dislocations, it's only, well, depending on what paper you read, 2 or 3% are posterior dislocations. It can be difficult to appreciate clinically because you don't feel the head of the clavicle sticking out like you would from an anterior dislocation. CT is excellent to make the diagnosis, much simpler than angled or rotated oblique plane films, and in detecting complications. Everything that lives under that spot is prone to injury. So in addition to the things we've already mentioned, we have the brachial plexus, recurrent laryngeal nerve, simply everything that lives back there. Now, one thing I've learned, and I was interested in what the mechanism of this injury is. So if you happen to be playing soccer or football and you're hit from behind laterally in this manner, what happens is the shoulder moves forward and the clavicle is pivoted such that the clavicular head is forced posteriorly. On the other hand, if you're hit anteriorly, the way the shoulder moves forces the clavicular head out anteriorly. So it's simply a vector of which force is being applied that determines which injury you wind up getting. Okay, trauma is bleeding primarily. What you're really interested is in figuring out what's bleeding and stopping it. That's what kills people most effectively. So we see a lot of chest wall bleeding, mainly from the intercostal vessels, and typically either this is penetrating trauma or this is going to be a rib fracture, which has lacerated the intercostal artery. Here we have a situation where the intercostal is bleeding mainly into the pleural space. It can also bleed under the pleura, and I'll show you an example later, and looks like an epidural hematoma. It's an epipleural hematoma. This is pretty uncommon, though. Usually it ruptures into the pleural space. Occasionally it simply bleeds out into the chest wall. So all things and combinations are possible. I happen to think that the most elegant way, once you've diagnosed this with CT, to repair it is by angioembolization, which is, I think, an elegant way to take care of this. Unfortunately, our surgeons still seem to think that they do a better job opening the chest and removing a few ribs and getting access and then tying it off surgically. If I were the patient, I probably would have something to say about that if I really understood what that meant. But the surgeons obviously make the ultimate decisions. Just one more example for you. Again, intercostal artery, intrapleural hemorrhage. This one's bleeding out into the surface of the chest wall. So you can say to the surgeons, hey, this is the intercostal artery from just beneath the 10th right rib. You can give them perfect directions on where they need to find it. I've had cases where the surgeons come out of the OR, brought the patient, basically intubated from the OR to have a CT scan so they could find where the artery or which artery was bleeding. So it doesn't happen a lot, but it's very upsetting when it happens. Okay, now we get a lot of knife wounds in Baltimore, gunshot wounds, knife wounds. We're always in the top 10 for murders in the country, so I have a lot of pride in my heart about Baltimore. But it's a good place to put a trauma center. Anyway, the point I want to make with this slide is, so this person's stabbed. You can see the track going through the chest wall. You can see it. It passes the lung and somehow reaches the posterior chest wall. And sometimes it's really hard to know exactly where the course of bullets goes, but it's a little more straightforward with knives usually. Anyway, there are two things bleeding here. There's probably an intercostal bleeding, which has to be stopped, and there's a lung bleeder right here, a little pseudoaneurysm. The whole point is, you're not going to fix this patient unless you've identified both bleeding points and they can both be addressed. So we're going to see what's more common, that's the intercostal bleed. The less common bleed in the lung parenchyma itself is just as important. So you have to do what we don't normally do very much, is look for bleeding from the lung parenchyma. So find all the sources. Here's another problem vessel, the internal mammary artery. It's going to be injured again from penetrating trauma, but can also be injured when there's a sternal fracture or a chondroid fracture of the rib. So what we see is, as we are in the arterial phase, we see contrast extravasation, and normally that's going to be held up in the substernal region. Normally that's going to be held in check. However, it can rupture through the pleura into the pleural space, and once that happens, it's a zero pressure or negative pressure space, and that blood's going to pour from that artery into the pleural space. So timing gets to be all of a sudden a big problem. So it can be a very treacherous site of bleeding that needs to be identified and addressed clinically. Here's another one that's more typical. It's again associated with a sternal fracture. Here's the bleeding point, and there's a small hematoma around it, which at least at this point in time is under control. Now, here's a situation. We have two different patients, and both of them are bleeding. You can see this patient down here has a very large body wall hematoma, which may take a while to be appreciated as the patient's under covers in bed and the hematoma is growing, and you're not seeing it because no one examines patients anymore. But occasionally they do pick up something like this. And so what do you do about this? Well, I asked this question to medical students, and they all say operate. I don't know who wants to operate here, but this actually, what this needs is a medical student to sit on this for about 3 hours. And that is the very cheap cure for this. On the other hand, here's a bleeder in the chest wall, which is probably a muscular branch, and you're not going to be able to suppress that bleeding because you're going to have to sit on the scapula, and you're not going to get good compression. So this is going to require angiographic intervention. All right, I'm going to let you just have a moment to look at this. Two patients, obviously bad blunt chest trauma, chest tubes in. Now there's something else here that you probably don't look for. And I put a couple arrows on, and what these are points of bleeding into the lung parenchyma. Just as serious as bleeding anyplace else in the body. I want you to notice in this case that some of the ribs are missing. Well, what the surgeons were doing is trying to figure out where the bleeding was coming from, and they're looking for an intercostal, and in fact what was bleeding is the lung. And what compounded this case was that the radiologist from my group didn't appreciate, because we so rarely see it, that this patient was in fact actively bleeding from the lung parenchyma. So when you have a patient, who has lots of contusions and lacerations of the lung, think about active bleeding also being present. It's relatively uncommon, but it can occur, and it can cause the death of the patient if it's not addressed. And how do you address it? Well, either you wind up doing a partial lung resection, or you embolize the most offensive vessels. So that's the only way you can approach this situation. All right, here's a good lesson for you. I used to do angiography, so I know how this works. So here we have an intercostal artery, which is bleeding. Okay, then we've embolized it, and this is the post-embolization result, and it looks like that vessel's been pretty neatly tied up. Okay, and then next day they say the patient's dropping their hematocrit, and we better do a contrast-enhanced CT scan to look for bleeding. And here's that scan the next day. Okay, so is the patient bleeding? Well, it looks like there's a lot of contrast hanging around. Okay, so what is this? This is pseudoactive bleeding. Okay, anytime you give contrast to a patient and embolize something, that contrast doesn't just go away. It sits in the soft tissues, and if you've given a lot of contrast, it's going to hang around within the hematoma that you've embolized, near the site of the bleeding vessel. So here's one circumstance when you know you're going to be doing a CT of a patient who's very recently gotten contrast for angiography, to do a dry scan first. If you know from that dry CT that there's no change from the two scans, that what you're looking at is contrast that extravasated during your procedure and is not new bleeding. Otherwise, you wind up going back and re-embolizing the vessel that already has been successfully embolized. Aortic injury has really been a challenging diagnosis, which has finally, I think, been brought under control by radiologists. And what's happened is the quality of our images is so good now, we can characterize these images far better than in the past. And we can see much more subtle injuries. Okay, so we see more subtle injuries. We have to know what to do with those more subtle injuries. One thing I've learned over the last 20 years or so doing this kind of imaging is mediastinal hemorrhage is almost always present with aortic injury. But as we see these less severe injuries, we see occasional cases where there's no mediastinal hemorrhage at all, yet there is an aortic injury. We have aortic intravascular stents now, and this kind of changes the whole balance of how we approach these patients because we have a spectrum of injury. Does everybody need to get a stent In my place, it looks like if you have an aorta, you get a stent. But I think it's logical to presume that there is a class of injuries to the aorta that are minor and will heal on their own and don't need to have a stent placed for the rest of the patient's life. So we need to understand better, or as well as we can, what the natural history of these more minor injuries are. It's still occasionally the case that a good CT, technically well-performed CT, will be indeterminate for injury. In those situations, my first fallback point is to go to endoluminal CT. Okay, so this is post-processing. You have the data. For me, endoluminal views have been helpful in determining whether or not there's an intimal tear or something else. If you have intravascular sonography, great. That will answer the question. Most people don't have it. Just doing a follow-up CT, or even better, a gated CT, will usually help resolve this. It's a rare situation that you may run into. All right, real quick, let's go through the primary features of a traumatic aortic injury. 95% in our experience are at the aortic isthmus, and this is very fundamental information. Almost all of them have a hematoma that surrounds the aorta and in most cases extends into the mediastinum. These pseudoaneurysms can be very smooth or very irregular. There's always intimal flaps. If you don't see intimal flaps, you're dealing with something that's a not acute vascular injury. You've got to see intimal flaps to assume this is an acute injury. Most of the time, the flaps have clot on them, not necessarily, but they may seem thicker than normal intima because they have clot, and we'll talk about these issues of coarctation in small aortas in a moment. Sometimes blood from the mediastinum tracks all the way down to the diaphragm into the retrocrural space, and it's important, and I'll show you for just in a moment why that can be so important to understand. Active bleeding, I've seen 5 cases of patients who were bleeding from the aorta, true ruptures. Bleeding when they came in, 4 have died, 1 survived with emergency stent placement. It's not going to be something you're going to see. Prototypic, classic pseudoaneurysms of the aorta, 2 of them very irregular, surrounded by hemorrhage, mediastinal hemorrhage going throughout the mediastinum. It tends not to go very far into the anterior mediastinum, tends to hang around the airway and the esophagus, and does push things around. The hematoma does, and the pseudoaneurysms are responsible for mass effect on the adjacent structures. Again, prototypic pseudoaneurysm. This case, smooth. Intimal flaps have to be there. It's pointing anteriorly towards the left main pulmonary artery and the left main stem bronchus. That's the most common location. Doesn't have to be that way, but that's the most common scenario, surrounded by a collar of hematoma. Now, I just want to point out that occasionally you have a situation where the lumen of the aorta is compressed, usually by the pseudoaneurysm. So the pseudoaneurysm gets big enough to compress the true lumen of the aorta. So what happens is the aorta below that level downstream constricts to maintain blood pressure. So what you wind up with is a small aorta, much smaller than you'd expect for an adult patient. Similarly, with this patient, we have a small aorta surrounded by hemorrhage. Okay, now why is this important? I know there's an aortic injury because I have the chest CT. Well, I'm just curious, show of hands. How many people work in departments where the chest and abdomen CT are read by separate people? Couple of lonely, sad hands going up. Okay, this doesn't happen very much. Most of the time, a study on a trauma patient is a full run through the body, and it's read by one person. There are still places, though, when the abdomen may be done as a separate study, read, or it may be done and no chest done. So the important factor here is to recognize the small aorta and the surrounding blood could be a secondary finding from aortic injury in the chest. So it will tell you, hey, I got to go back and look at the chest X-ray, or more likely go look at the chest CT and make sure there's not an injury to the more proximal aorta. Here's one of those patients with active bleeding, true rupture, and this is a totally metastable situation. The patient will have an intact pleura, which will be holding back the blood, arterial pressure blood, and eventually that'll go at some point, and once that happens, it's over. So, you know, I've seen patients that come in, they're talking, they're not necessarily happy, and then they go like that once the pleura ruptures. Now, things that confuse people are usually variants of the ductus diverticulum. So you have to get used to the range of this variant. Usually it's very smooth. Okay, it has no, nothing, no intimal flaps here. The edges are typically obtuse, not acute. Here you can see a patent residual ductus. Okay, here's one that's calcified. We see this a lot, a little remnant of the ductus which is calcified. Sometimes, though, they have an atypical appearance, like a little box or rectangle. What's important to recognize is there are no flaps and there's no mediastinal blood. No mediastinal blood is a very powerful sign that this is not a true injury. And if it is a true injury, it's probably going to be a minor injury. So you have to look carefully to figure out what you're really looking at. Is it blood in the mediastinum, or is it a lot of other things that is not blood in the mediastinum? So these are pretty peculiar appearances, and I admit in the right clinical circumstance you might be a little bit afraid. If that were to happen, you have the options of doing other studies. You have the option of rescanning the patient, putting them on low pressure support, trying to keep their mean arterial pressure down. There are ways that you don't have to immediately go in and treat this with a stent, but of course that's going to depend on your surgeons and how they approach this. But I want to tell you, these are variants that can occur, and they look like this, and they are just variants. So smooth walls, obtuse margins of the outpouching with the aorta, no intimal flaps, and no mediastinal hemorrhage says I'm not an acute injury. All right, the other thing that's been mentioned, and I must say I don't see the problem here, are diverticular origins of the bronchial arteries. And so sometimes you get this little outpouching at the takeoff of the bronchial artery from the aorta. And there's no mediastinal blood around it. It's smooth, and if you want, you can follow it as it heads towards the carina and mainstem bronchi. So you can assure yourself very quickly that this ain't an aortic injury. But it's in all the books that this can be confused with an aortic injury, but I think that would be difficult. Couple of individual provisos I want to mention, things that you should be aware of. Bad fractures of the T-spine, that is distracted or very displaced fractures, high energy injuries, can also injure the aorta. Okay, this was once said to be impossible, and we all know nothing's impossible. So we looked at this in our own experience, and we looked at 70 patients who had bad upper thoracic spine injuries, and 4 of them had concurrent aortic injuries. And this is just an example. This is the same patient magnified up a little bit. There's something in the literature that says 8 out of 11,465. I don't believe that. So this is rare. All I'm telling you is that if you see a high-energy displaced T-spine fracture, make sure you check out the aorta because it can be injured, and you need to pick that up. The other thing we can see that isn't supposed to happen is a dissection, traumatic dissection of the aorta. People use this term incorrectly. They say the patient had a traumatic dissection. Most aortic injuries are just injuries. They're not dissections through the media. Okay? This, in fact, is a dissection of the aorta down the media. So the tear in the aorta normally burrows up into the serosa, which is pushed, the adventitia rather, which is pushed out and maintains the integrity of the aorta for some period of time. But the tear can also rarely stop in the media and then dissect the media just like any other medial wall dissection. Okay, so you can get something that looks like a type B dissection. In the cases I've seen, there has been no reason. These were young people who had no history of any condition that would suggest an abnormal aorta. But it's been very rare. Now, I will tell you, and this is not an ethnic point, I was talking about this in a lecture in Japan about 10 years ago. And the Japanese in the audience, mostly surgeons, were either unconscious, sleeping very deeply, or just not damn interested at all. I mean, it was really tough to talk. Oh, you guys are at least awake. Anyway, most of you. I mentioned this, and everybody woke up suddenly. And they said, oh, we see this all the time. Okay, so if you go to Japan and practice, you're going to see this all the time, so you better take note that it exists. And they're treated like type B dissections. Something else that can happen is clot forms on that intima, okay, and it can embolize. So here we see a patient who has renal infarction bilaterally. Here we see a patient who has splenic infarction. So just beware that that clot sitting there is certainly can embolize, and so managing this with antiplatelet therapy or if you can, anticoagulation, which is difficult in the trauma patient, but you have a potential source of continued damage there. Now, I just want to mention this discussion of minor aortic injuries because it's a relatively new topic. And what we're talking about is a subset of injuries that involve the intima primarily, but also can produce very small, shallow pseudoaneurysms. And there is debate about this point, so I'm not going to say all of this is in concrete at all. So what we've done is we looked at patients who had intimal flaps with or without clot, or intramural blood, that is dissection that was just in the wall of the aorta, or very small pseudoaneurysms. And we picked this out of thin air. We said a pseudoaneurysm which is no more than 10% greater diameter than the normal diameter of the aorta. So here's the normal diameter. Here's the diameter at the point of the pseudoaneurysm. If that's a less than a 10% increase, that's okay. That's acceptable as a minor injury. Other people have used up to a centimeter in the size of a pseudoaneurysm as being minor. Well, if you have a 25 millimeter aorta and you have a 10 millimeter pseudoaneurysm, you got a problem. That's a big pseudoaneurysm. So I'm just saying there's other points of view. In any event, and this is this is hemorrhage in the wall, and there's another minor injury. And really quickly, I'm going to show you just what these look like. They're just usually very small outpouchings like this, or they're very small intimal flaps. And here's one we followed, and we got a one-day follow-up, and it's started already to heal. And at 13 days, this has disappeared completely. And we followed about 25 of these patients now, and so far so good. None of them have worsened. None of them have developed larger pseudoaneurysms. So here's another one just to show you the typical intimal flap with clot, and then it goes not completely away, but at 2 days it's getting better, and then at 8 days it's gone. There's still a little contour abnormality, but essentially the lumen of the vessel is clean. We don't think much about venous injuries in major chest trauma, but we have other possibilities, and here is a pseudoaneurysm, and you have to think about, well, where is this coming from? This was blunt trauma, okay, and this happened to be coming from the pulmonary artery. The pulmonary artery is rarely a source of major vascular injury. It may not be bleeding acutely, but it certainly can become a significant source of hemorrhage either at the time of admission or suddenly soon after. Here's another injury to this is the left main pulmonary artery, and there's just a little tear here. This one looks like it's probably not going to get very far, but it still has to be embolized if you identify it, because it will bleed. This one I'll leave up to you guys to tell me what's bleeding. You can't hurt this person. Okay, this is a slide. This is an imaging. So anybody, what vessel is this? Azygos. Thank you, sir. Okay. Cupidal. No, seriously, that's good. It's an azygos vein bleeding. Usually what this will do clinically is produce a hemothorax on the right and a right-sided mediastinal hematoma. This is unusual to tear down here. Typically they tear as the azygos goes over the right main stem bronchus is where they tear, or at the insertion into the back of the IVC. So again, rare, but this will kill the patient if you don't figure out where it's coming from. Okay, just a few comments because we're going to run out of time on esophageal trauma. Very, very rare from blunt trauma. There are only a handful of cases since like 1980. It's an extremely rare diagnosis. And so if you think you have it, you probably don't. We very seldom identify this early on in the clinical presentation of the patient. Most injuries to the esophagus are iatrogenic. Less than 10% are going to be due to trauma in some form. The esophagus is sitting in a perfect place between the spine and the anterior chest to be crushed in an anterior impact. Knives and bullets don't care where it is. It'll go through the esophagus and the major vessels and the airway through the mediastinum, and so that's certainly a possible source of injury. The one I think, though, is probably the most common is imagine your chest gets compressed. Anterior to posterior. And here are the main stem bronchi. Where are they going to go? Where are they going to go outward? There's no place else to go. They're going to be forced outward. And just like the wishbone of the chicken, one side or the other tears. And it's usually the right side that tears, and usually pretty close to the carina. Here's a patient who actually does have the injury, a combination of airway injury and esophageal injury. anytime you have a tracheal injury, think about the esophagus. Anytime you have an esophageal injury, consider the trachea. They're very close together, and a high degree of energy that injures one can certainly injure the other, as well as the aorta. So clinically, there's very few specific symptoms. Radiographically, you may see widening of the mediastinum, very nonspecific. You may see some left pleural effusion because it tends to tear at the inferior aspect. I got you on the timing. And so you may see that, and you may see some free air, but you're not likely to see a lot of free air. The free air tends to stay pretty close to the injury site because it's not under pressure. In the trachea, air is under pressure, it's going everywhere. Okay? So that's not going to be the same situation with the esophagus if it ruptures. And I guess we'll end with this one. This is a fellow who, well, he ran into a problem, self-design. So I hope you would all agree that his pre-cervical soft tissues are a tad full. Okay? And some images. He came in complaining of a sore throat. And he has all this air in his mediastinum. The esophagus looks very odd. Then there's this huge abscess in the same neighborhood as the esophagus. And what did he do to get this? He swallowed his dentures. Don't do that. Okay, don't swallow your dentures. All right, I'm sorry I didn't have enough time to get through everything I wanted to. I hope you got some good points out of this. Thank you.